Now that I've started recording, Josh, I'll just tell you that I was filling in Simone about where you're up to with your training, and that we were just chatting about what we're going to do for the next sort of round. So for everybody that is tuning in that haven't been with us from the beginning, what we've been doing is just working our way through Edinger. So we sort of do 1 to 3 chapters a week, depending on how big the topic is. And we've been keeping the level of discussion around about sort of membership level of study. But now that we are officially on the last chapter of Edinger, we're going to start moving towards upping the discussion a little bit to including some more fellowship stuff. So I'm going to be tapping Josh in to do a little bit more of the kind of background research, introduce some papers and things that might be good resources for anybody that's studying for either sort of a high level of medicine, masters or memberships, but particularly fellowship exams. So that all kicks off in a fortnight. I have no idea what the chapters are that we'll be doing, but they'll be up on the website within the next week. So just keep an eye on that. And obviously the social media stuff will all come out as well the week before. So you've got a bit of time to prepare. Basically the way Edinger works is it goes through clinical presentations and then it goes through body systems. So the next several months are going to be very much case-based. This is what you're presented with, a vomiting dog. What is the mechanism of vomiting, which is actually a membership question that I got when I sat memberships. So it's very kind of membership level kind of approach. And it's really clinical and nice to kind of sink your teeth into because you can really imagine how you manage cases and then try and translate that to how you'd answer an exam question. So that should be fun getting started again. But today we've got a fairly kind of open-ended topic, which is concurrent infection and immune suppression. So has anybody dealt with an immunosuppressed patient who develops an infection?
Yes, definitely.
All the time. Yeah, I think this is something we see really commonly. So I want to sort of start, we're going to get a bit philosophical here, and there's often no right answer because everything you do is a compromise in these cases. So I want to keep this quite a discussion rather than me saying this is what I do, because you're going to get a different answer and there's going to be different perspectives, and we've all dealt with different cases that have made us go this way or that way in certain situations. So the first thing I wanted to talk about is, what is the immune system's job in health?
Yeah, it's I guess it's to try, or just to defend the body from infection, really, or from pathogens.
Yeah, from pathogens, good. And does it have a role in prevention of reactivity?
Yes, it does. Yeah, I guess it's like always constantly like sampling and trying to determine what is good, what's bad, when and how appropriate that response should be.
Yeah, exactly. So 2 roles mostly. One is prevention of infection or defense against infection, and emerging neoplasia, we should say, as well. So there's the defense aspect of it, and then there's also the tolerance aspect of it, which we should keep in mind, because this is a system that's just antigens get chucked at it and it needs to decide what it needs to respond to and what it needs to tolerate. And they're both really equally important functions, because when we talk about immune-mediated disease, what is that?
It's when the immune system is either overreacting or targeting inappropriately.
Yeah, exactly. Yeah. So it's an inappropriate immune system response. So understanding what's happening in the immune system and why we might be using immunosuppressive medications, I think, is really nice to have in your mind. So what is inflammation in the body? What drives a pyrexia, for example?
Cytokines. Sodium.
Good. Yeah. Which are produced by
Never really thought what they're produced by.
I was like,
sorry?
in ortho, was it all inflammatory cells?
It's most of them. Yeah, most of the cells in the immune system will have the ability to produce different cytokines. So like eosinophils do one type, lymphocytes do IL-2, the acute phase cytokines IL-1 and IL-6. I want to say macrophages, maybe endothelial cells and stuff as well. But essentially the first responder cells are the ones that are responsible for pyrexia development. And essentially inflammation is the immune system responding to something. So how do we know whether the immune system is responding because there's an infection and it's appropriate, or as there's dysregulation and we've got an inappropriate immune response?
That's a good question.
This is going to get philosophical.
There's a really good, I'm looking forward to it again, that there's a great chapter in very early on about fever, and it talks about like how, you know, obviously it's not the worst, it's not a bad thing in all ways, but when do you draw the line? I guess when is it impacting, I don't know, I guess fever always impacts you, but when it's causing, like when it's life-threatening, I don't know.
Yeah. When it's such that you can't eat and that's going to delay healing or something, you know, there's got to be a sort of line in the sand where inflammation becomes dysfunctional rather than functional. And in particular, when we're dealing with working out whether a fever is due to autoimmunity or appropriate response to infection, I think that's a really challenging situation clinically. Richard Malik once said to me that autoimmune diseases are almost certainly infections that we haven't identified yet, which is a really interesting perspective, isn't it? Something's triggered that immune system to respond, and we know that there's certain autoimmune diseases where we get that molecular mimicry and it's a true autoimmune response to self-antigen, but there's a lot of autoimmune diseases that we treat, like hepatitis, where we don't know what the trigger is and we don't know whether there's active infection going on. Can anyone think of any other examples of where there might be active infection triggering autoimmunity?
We I don't know if anyone else here did, but there's a great talk by Andrew Macken last night on IMPA, and so talking about like reactive IMPAs.
Yep, that's a really good example. There's almost always something triggering that, and it's almost always either excessive antigen or excessive antibody. So you either got excess immune response or you've got antigen in there that you haven't identified yet.
Glomerulonephropathy, but
yep.
I don't know.
Yep. And that's another example of where that immune response, that inflammation, is actually going to be damaging and detrimental to the kidneys down the track. So whilst there might be an active infection there, it's the immune response that we need to dampen down. What was one of the treatments for COVID when people were being admitted to ICU with pneumonitis?
Like what they were using? Is that what you're asking?
Yeah.
Were they using remdesivir? So FIP.
Sorry?
Remdesivir?
Oh, yeah. So they were once they sort of worked out the antivirals. But there was one treatment that wasn't iodine. Trump.
Was it Dex?
Yeah, it was Dex.
Oh,
everyone's talking about this miracle drug that reverses the pneumonitis, and I'm like,
it's a bit of a miracle drug, definitely.
It is a miracle drug. So yeah, that the degree of inflammation, like we've got an active infection, we've got active viral infection, we know about it, but the degree of inflammation is life limiting. So we actually need to dampen the inflammation to get this patient through to survive, to be able to then treat the viral aspect of it. So it's actually the inflammation which is causing the disease in this situation. The virus caused the inflammation, but it's the inflammation or the immune system which actually causes the life-threatening aspect of the disease. So I think there's this sort of fine line, and there's a good, Edinger references a good review in Human Medicine where they talk about that line where there's you need to decrease the inflammation to get the patient through, knowing that it's going to exacerbate the infection or the number of infectious organisms there. So it's fine to sort of suppress that inflammation as long as you've got the appropriate antiviral, you know, or the appropriate antibacterial, you know what infection you're dealing with, you know you can clear it as long as you get the patient through that first kind of critical period. And we talk about using corticosteroids in critically ill patients who are volume, like isovolemic, and have hypotension despite being given presses and things. So that corticosteroid associated, critical illness associated corticosteroid insufficiency. We've talked about that in the endocrine chapters. So that's something that we know in critical patients, often they're septic. We know that that's the only thing that sort of stabilizes their blood pressure. And sometimes we just have to use anti-inflammatories to stabilize membranes and things. Or immunosuppressives, essentially. So anti-inflammatories, immunosuppressives is a bit of a blurry line. So going back to that comment of all autoimmune diseases are infections we haven't isolated yet. What is shifting in the way that we test for particularly bacterial infections that might help us to identify infections more accurately and faster? Can anyone think of new? So we used to culture everything, right? We used to have to wait 2 days. Do you know what percentage of bacteria in the world are culturable in a lab environment?
1%.
1%.
Not even.
Not even, exactly.
Oh, wow.
Yeah. What about bacteria on bodies? How many of them are culturable in a lab environment? That you'd
More.
find. Hey?
I imagine it's more than 1%.
Oh, it's much more than one. Yeah. It's 40.
40. Okay.
Yeah. So definitely less than 50. There's papers that go sort of 30 to 45. So you can imagine if the vast majority of our infections are caused by commensals, there's a lot of them that we're culturing and going, oh, no infection. And actually there is an infection there. And so I did a bit of a rabbit warren deep dive once I was sort of researching this and looked at the kind of hit rates on just urine culture, because I think that's probably one of the places we look most commonly for a source of infection. And a culture was accurate in 37% of patients. Well, it grew something in 37% of patients who were suspected of having a UTI. So there's going to be a lot more of those patients had a UTI. So what other testing might we be able to do as we get more technology around
doing like molecular PCR testing?
Good genetic testing for bacteria. Exactly. Yeah. So we might not be able to grow them, do sensitivities on them, speciate them, but we can say there was bacteria here because there's that like 16S component of genetic material within the sample that was submitted. And then if we know what organism we're looking for, and as we can do more broader genetic scanning of genetic material, we might be able to speciate those bacteria with the like a PCR-based test or a genetic-based test. So in humans, they're looking now at detecting UTIs and the correlation between culture and PCR. So that stat that culture grew 37% of patients. The PCR detected infection in 56% of patients. So that's sort of knowing what bacteria to look at. And interestingly, what are the limitations of culture?
But time is one of them, but also not everything can be cultured either.
Not everything can be cultured. Yeah, exactly.
They need to be alive too.
Alive, yeah, exactly. So if you like, even if you've like prepped with Chlorhex or something like that to do your cysto, you could get a little drop of Chlorhex in your urine sample and nothing's going to grow. And the other thing is that a lot of UTIs are polymicrobial, and you submit this sort of sample in the lab, and the dominant bacteria, the one that's kind of best at living in that environment, is going to grow, and it's going to take all the nutrients from the other bacteria that are in there, and those ones aren't going to grow. So that's where I think the PCR, which is run immediately before there's kind of been that sort of change in the population, are potentially going to be very useful for us detecting infection down the track. All right, let's talk about how immunosuppression, what types of immunosuppression do we see? So there's sort of naturally occurring and acquired or iatrogenic immunosuppression. Let's talk about the naturally occurring.
Like Cushing's.
Cushing's, good. Yeah, perfect. If you think about the elements of the immune system, somebody give me what the elements of the immune system are. Broad categories.
I mean, like the innate and adaptive.
Yes, good,
immune
excellent.
system.
And then the last category is the kind of barriers, physical barriers and stuff like that. So there's sort of three categories. There's the physical barriers, which kind of form part of the innate. And then we've got the cellular component of the innate system. And then we've got the humoral system. So if we think about what's a disease where we've got loss of barrier function that predisposes to infection development?
IBD.
Good. Yeah. What about skin? We don't like to talk about skin, but
Skin too, yeah.
I think that's the most common one we see is atopy with secondary skin infections, right? It's just the loss of that skin barrier, healthy skin barrier. And then things like ciliary dyskinesia and dysfunctional mucociliary clearance system, chronic bronchitis, things like that. Gingivitis, dental infections. What about, can anyone think of a disease of the innate immune system, or the cellular component of the innate immune system, which predisposes to infection? Which this is a really good example. One of them is a really good example of, we used to think it was autoimmune, and we recently discovered it was infectious. I'm obviously thinking of something very specific. I'm sure there's a lot of examples.
Like a Ehrlichia or something like that, or like a rickettsial.
Oh, yeah. Oh, yes, for sure. And where I think some of that's kind of emerging in Australia with the investigation into this limelight disease. But the one I was actually thinking of is the histiocytic colitis.
Okay.
What's
Yeah.
the etiopathogenesis of histiocytic colitis?
It's like the what do they call it? The enteropathogenic E. coli, isn't it? They kind of live inside the cells.
Yes. Why do they live inside the cells?
Because they can camouflage themselves. Basically, I can't remember the method of it, but they can avoid the immune system.
What is the genetic component of that disease? Because it's familial, isn't it? What breeds do we see it in?
Yeah, like Frenchies, boxes, yeah.
Boxes and Frenchies. Good. So it's definitely familial. So that implies that it's not an organism factor, it's a host factor.
Yeah.
It's really cool. Can I tell you?
Yeah.
So the neutrophils can't produce peroxidase, which is one of the lysosomal enzymes. So they eat stuff and then they can't kill it. So it's actually an immunodeficiency in neutrophil function. The neutrophils can't kill the bacteria that they phagocytose. So then the bacteria just then replicate within the neutrophil, and then you get this really big immune macrophage response or histiocytic response, causing histiocytic colitis because the neutrophils aren't doing their job and the macrophages are like, neutrophils, now we're going to have to eat you. And yeah, it goes on. So I thought that's a really interesting one. And then there's other like specific neutrophil deficiencies, cyclic neutropenia and things in grey collies and stuff like that, really rare stuff. What about any acquired humoral immunodeficiencies? Can anyone think of any of those? Not acquired, sorry. There's a infection that only cavies get, and another one that only.
Pneumocystis.
Yes.
Yeah.
Yes. Why has that happened? Do you know?
No, I kind of think of it like ulcerative colitis as well, or granulomatous colitis as well, like similar kind of thing. But I don't know if that's true.
Actually, IgG deficiency. So if you
Okay.
compare immunoglobulin levels in these cavies relative to other
Mhm.
cavies, they've got a humoral immunodeficiency. They've got decreased immunoglobulin levels, which predisposes them to pneumocystis, which is seen in which human disease? Does anyone know? It's seen with AIDS or HIV/AIDS complex. So that lymphocytic deficiency or functional lymphocytic deficiency results in an IgG deficiency, which results in infection. All right, so let's move on to acquired causes of immunosuppression. So the reason I mention those is because we often skip them in our minds as far as what might be causing immune deficiency or immunosuppression in this patient. And it can definitely be barrier function, genetic, innate or humoral immunodeficiency, but I don't want to spend too much time on them. What acquired ones we see? We talked about Cushing's. What about iatrogenic? What situations have we immunosuppressed patients in?
By giving them bread.
Yeah, exactly. And there's so many reasons why we might give them pred. There's so many dogs with atopy that have chronic prednisolone dosing. Otitis externa, we use topical pred, we use like lots of different sources of it. And inhaled as well. What about, why don't we just make that immunosuppressive medications as a category? Let's talk about how glucocorticoids actually cause immunosuppression. Does anyone remember? There's got lots of different mechanisms, so throw something out there, you're probably right. Why?
Is it T cell suppression and I think lysis as well?
Yep. So lympholytic effects. Yep. So it decreases T cell activity. What are T cells' job relative to B cells?
B cells produce antibodies. T cells are
T cells tell them
killer
to.
cells and like different types.
Yeah. So T cells are the directors. They tell the B cells to produce antibodies. They tell the innate immunity to up its game. They produce cytokines which ramp up or dampen down the immune response. So they direct the response. The B cells then mediate that response. They actually produce the antibodies and generate that humoral immune response. So decreased T cell activity, which means we've actually got dampening down of the entire immune system because we've got less cytokine activity from those T cells. Any other effects? So that would take a while, wouldn't it? Because the T cells will stop producing cytokines when you start the pred, but the cytokines that are already out there are still working. But pred works pretty fast, doesn't it, when we're treating autoimmune disease? What other mechanisms might it have that work fast?
It's also an anti-inflammatory, so I guess it's inhibiting, I think, prostaglandin and the COX pathways.
Love it. Yep. So that's the arachidonic acid pathway.
Yeah.
Suppressing. And we know where non-steroidals work on that pathway, don't we? What do they inhibit? You said it already.
Yes.
Yeah, the COX pathways.
Yeah, good. So do you remember it sort of branches like that? Pred actually suppresses up here at the phospholipase A2. So it inhibits that whole inflammatory pathway. And that's used for activation of platelets, activation of a lot of the white cells. So we get decreased activation of that innate immune system as a result of decreased activation of that pathway. So phospholipase A2 inhibition. And then there's one other thing that I find really cool, particularly with like IMHA and IMT. it blocks off the FC receptor or decreases the number of FC receptors on the macrophages. Do you remember what the FC receptors do?
Something to do with IgE, don't they
Oh.
bind IgE?
Exactly. So you've got your antibody. How do you make a piece? I can't do it. Antibody, right? And this knuckle is your FC region, and these tips of my fingers are the FAB regions. So the FAB region binds onto the target antigen, and then the macrophage finds the FC region, binds to it, and eats that cell. So if you've got antibody-bound red cells, for example, in IMHA, the macrophage is going to find those and eat them. But if PRED has blocked off or decreased the number of FC receptors on the macrophage, you're going to decrease the macrophage activity. And that works almost immediately on dosing. So it works within really two days or so. So that's one of the mechanisms that we rely on, and why we can't really ethically do studies not using or using other immunosuppressives instead of glucocorticoids, because none of the other immunosuppressives work on that pathway. Does that make sense? So that's why every single patient with IMHA or IMTP should get prednisolone unless there's a huge contraindication for it, essentially. Good. What dose of prednisolone will result in immunosuppression? It's got dose-dependent effects, doesn't it? We can decrease the inflammation by that phospholipase A2 inhibition and macrophage inhibition without necessarily getting the cytokine changes as well. What dose do you typically use?
Like 2 mg per kg per day.
Yep. So there's been some papers now. We used to say 2 to 4, didn't we? Been some papers now showing that 2 is just as effective as 4. There's also a lot of information now that prednisolone has immunosuppressive effects on kind of a sliding scale, and we've all dealt with those, like, you know, golden retrievers are really heavy dogs, and you put them on 1 mg per kg BID and they melt, don't they? Can't get in the car, can't breathe, urinating all over themselves. So there's Lauren Trepanier, who's done a lot of the kind of pharmacology work that's in like CVT and a lot of the veterinary literature. She recommends a maximum dose of 50 milligrams per meter squared for 24 hours. And if you think about the dogs we're often treating, like 40-kilo dogs, it's actually, that'd only be like 60 milligrams total dose. So she does a sliding scale, like a body surface area scale, rather than a per kilo dose. All right, what other immunosuppressive medications do we use?
Azathioprine, cyclosporin.
Good. Let's talk about azathioprine. What mechanism does that use to suppress immune responses?
Is it calcineurin something? Again, works on T cells.
Oh, cyclosporin's calcineurin.
Okay.
I think azathioprine inhibits purine synthesis.
Good. What's purine?
I think it's one of like the basic DNA stuff.
Good. Really good. I feel like that was like such a light bulb moment in my fellowship study. I was like, oh. So if you limit a cell's ability to create DNA, it just apoptoses. Apoptoses? I don't know what that word is, but it essentially is shut down. So why, if we give azathioprine, why do lymphocytes preferentially get shut down over all the other cells in the body? Because every other cell needs DNA, doesn't it? Can I tell you? Yeah. So the lymphocytes are the only cell that don't have an alternate pathway for purine synthesis. So they rely exclusively on the pathway that is shut down by azathioprine, and there's another drug, two other drugs that work on that. pathway as well. So purine analogs or purine synthesis inhibition. Can you tell me what they are?
Is it mycophenolate mofetil and leflunomide?
Very good. Did you study for this or do you just know that?
Oh, I studied for memberships for this.
Oh my gosh, that would have exited my brain immediately after that.
Yeah, coincidentally, I actually looked it up yesterday.
So lucky.
Yeah.
I mean, yeah. Good. So they're the inhibitors of DNA synthesis or purine analogs. What about calcineurin inhibitors? What are the names of the drugs?
Cyclosporin.
Good. And there's another topical one we use sometimes for dry eye or
Is it tacrolimus?
yes, exactly, same class of drug. But we just don't have a systemic version of that one. Good. So how do they work?
I think they actually inhibit like T cell stuff and also like production of IL-2, which is important for T cell proliferation and differentiation.
Good, exactly. So IL-2 is the main cytokine that ramps up that humoral immune response. So T cells produce IL-2, and what the calcineurin inhibitors do is just prevent essentially the signal getting into the nucleus to result in transcription of IL-2. So we block off production of IL-2, which in turn decreases numbers and activity of the lymphocytes. So it takes a while. I mean, I shouldn't say it takes a while. The purine analogs take a while to kick in, whereas cyclosporin is within a couple of days. So relatively, Predac first, then cyclosporin, then azathioprine if you're using all three. You should never use 3 based on the consensus statements. 2 should be adequate, so 1 of each class. And you shouldn't use any of the purine analogs together. So like mycophenolate and azathioprine together, you're not going to get any increased benefit. So just make sure that you're sort of selecting your immunosuppressants based on that. Okay, what other medications might we give not with the objective of suppressing the immune system, which might have the off-target effect of suppressing the immune system? We give them to cancer patients.
Oh, it's not cytarabine, is it?
Just all chemo, myelosuppressive chemo. Yeah. So what are some of the most myelosuppressive drugs that we give in our chemo protocols?
Like vincristine.
Mhm.
That's chemo.
Yeah. So, and yeah, they're all, basically all chemo drugs, but it's one of the biggest risks of chemotherapy is acquired infection, isn't it? Because we're suppressing the immune system. So I just want to cover that when we're talking about concurrent infection and immunosuppression. That's one of the iatrogenic things that it's very obvious, but if you're in an exam situation, it didn't pop into my mind as an immunosuppressant. So it's nice to just have that in your list. So vincristine is not listed as a myelosuppressive drug, but we see that it can cause myelosuppression with cumulative effect. But doxorubicin for sure, lomustine, cyclophosphamide, carboplatin, I think. Yeah. You can look at that.
We recently had 2 cases, Anna, because we do chemo at my place, my place as in my workplace. Epirubicin, we had within a week, 2 dogs with lymphoma getting epirubicin came in with adverse effects, and they eventually both died. They developed angioedema to begin with, and then one of them went into respiratory sort of compromise, so requiring oxygen supplementation. So we actually wrote to the company because we don't know whether that was a batch issue because it's not listed as a adverse effect. Both passed
What
away.
did they
within
have,
a
did you
week.
say?
Like
Edema?
angioedema, severe swelling all over this face. It started with that, and then they developed dependent edema. So we're thinking because it happened, both these dogs got epirubicin in the same week, and they presented the next week. So we're thinking it's a drug-related adverse effect.
That's
most
bizarre.
likely.
Yeah.
And it's not listed. It's not like we obviously looked it up, and it's not listed. But they both.
They
We couldn't say
died.
both. Yeah, we couldn't say either of them.
Did they develop myelosuppression? What did they actually die of?
So one of them, so one I think went into sepsis.
Oh,
Like
right.
severe, and
So
this was
neutropenic?
so neutropenic, and they both were hospitalized for a good 4 or 5 day period.
Oh,
The other one went into severe, like we're thinking ARDS eventually.
yeah. Oh, wow. That's very traumatic. So it's
But
not.
you
it's
haven't heard of anything with epirubicin like this, yeah?
No, but I have to say I'm not dealing with any
Yeah.
chemo at the moment at all. It would be interesting to call Sash and just see if they've seen anything, because they're probably doing the highest caseload in Australia. And yeah, maybe even let them know that that's happened.
We did. We wrote to the company to find out, because we were like, is it a drug like a batch issue or?
Yeah, that's scary. Yeah, it's not often. So I don't work in oncology, and I've always worked with oncologists, so they kind of deal with the patients. So I don't have a kind of sense of what percentage of patients who are getting chemo end up with medicine having an adverse reaction, but it's very low, and the hospitalization rate is less than 5% of dogs getting chemo. We know that just from the lymphoma spiel kind of thing, and the death rate associated with those ADRs is very, very low, because we're pretty proactive with the prophylactic antibiotics once the neutrophil count drops below. Does anyone know the recommendation?
Normally they say 0.75.
0.75.
Some people do 0.1 though.
Yeah.
Sorry, not 0.11. I mean 1.
1.0. Yeah, exactly. So I mean, Eden just says 1.0. But different oncologists are going to use different ranges. But 4 is the cutoff at most labs, 4,000 neutrophils. And if it drops between 1,000 and 4,000, they say there's no indication for prophylactic antimicrobials. But if it drops below 1,000, whether the dog's unwell or not, they should be on prophylactic antibiotics. Okay, should we talk about some cases? I've got a couple of cases I wouldn't mind having a bit of a brainstorm on. If you can help me, please.
Yeah, sure.
So I saw a 12-year-old male neutered Maltese cross who had mildly elevated liver enzymes a year ago, like ALP 212 and ALT 140 or something, like really borderline, not of concern, wasn't looked into. And then we repeated the liver enzymes a year later, just a routine pre-GA. The dog's well. And the ALP's 6,000. And the ALT 1,400 or something, but quite elevated. I did an ultrasound, and the liver is really big, nodular, quite diffusely, but then with one kind of big nodule, and the gallbladder looks really active. So I aspirated the gallbladder, and the cytology showed neutrophilic inflammation and a multitude of rods in there, and the culture's negative, annoyingly. Like, there's bacteria in there for sure. And then we did a true cut of the liver, and that showed a combination of neutrophilic and lymphocytic inflammation with quite severe fibrosis. And the inflammation hugs the portal tract, the portal triads. So it's very kind of periportal in its distribution. So this dog's diagnosis is neutrophilic lymphoplasmacytic hepatitis. And we've got some soft evidence of bacterial involvement in the biliary tract. Do you immunosuppress this dog with the fibrosis?
But then also, like with the fibrosis, some people say it doesn't, like you can use immunosuppression, but it doesn't really do anything.
Won't reverse the fibrosis, but you can limit.
Delay further. Okay. Yeah. I think you first need to do. I would think you first need to deal with the neutrophilic hepatitis.
Yeah.
And maybe use anti-inflammatory doses in the beginning, and then maybe ramp up depending on how.
How it's going. Yeah. Yeah, I found that one really hard. And it's a situation I've been in before. I find that because often bile culture is negative. Do we know what the most common organisms are in bile?
I mean, your enterogenic pathogens, so E. coli. by far.
Anaerobes.
And Enterococcus as well, I think.
Yeah. And yeah, a lot of anaerobes as well. So a lot of organisms that won't grow in culture unless you put them in a anaerobic culture vial. So anaerobe staph and E. coli are the most common we see in cats. In dogs, I think it's a little bit different in dogs. I can't remember, but all that Enterobacteriaceae essentially. Yeah, so in this dog, I did prescribe a combination of fluoroquinolone and amoxicillin clavulanate because we don't know whether these rods are anaerobic. Oh, sorry, beg your pardon. I used metronidazole and fluoroquinolone and rofloxacin. The reason I did that is because there was no cocci, so I don't think we needed that gram-positive spectrum that amoxiclav would have provided. There were rods, so they could easily be anaerobes, particularly given that they didn't culture, and therefore I thought metronidazole was going to get into the gallbladder in high concentrations and kill any anaerobes. And then the rest of the rods that we would see should be sensitive to enrofloxacin unless they're resistant. And we just don't know that because the culture is negative. So I started this dog on antibiotics and liver support, so hepatoadvanced, denameron, vitamin E, and SAMe in it. SAMe, milk thistle, and vitamin E in it, and some ursofork. What does ursofork do? Why would I prioritize using ursofork in this patient?
The colorectic, so you don't want that one.
Yeah. So in theory,
it's antifibrotic as well, like to some
Yeah.
extent, there's some
It's got
antifibrotic.
really amazing antioxidant properties in the biliary system, where hepatoadvance has them in the hepatocytes. The ursofork is excellent in the biliary system. It also works as a thiol donor. So when we've got periportal inflammation, remember that portal blood is carrying all the toxins from the gastrointestinal tract, and we've got inflammation around the portal veins. But right next to the portal veins is the biliary sinusoids, canaliculi. Yeah, canaliculi between the hepatocytes, the actual biliary vessels. So we don't know whether that inflammation is responding to bacteria in the biliary system or reactive hepatitis from the gastrointestinal tract coming from the portal vein. So I kind of want to do antioxidants for the liver itself, regardless of what it's responding to. And then the choleratic to decrease if there is bacteria ascending up that biliary tract. The choleratic is going to help flush it out just by increasing flow in that. So, one of the ways that we kind of encourage clearance of a UTI is to ensure that patients are emptying their bladder completely. Kind of same theory, right? So work in progress, but yeah, I think it's an interesting discussion, like whether you immunosuppress these patients or not. And I've said we'll recheck the liver enzymes in a month, keep them on antibiotics for the full month, recheck the liver enzymes, see what sort of response we've got to that therapy, with view to hopefully having cleared the infection and being able to start on some prednisolone or cyclosporin. I quite like cyclosporin if there's not active infection with hepatitis, but yeah, this one's a little bit tricky with that bacteria.
To me, the bigger question is how long do you continue the antimicrobials? Like because how do you retest if you don't have culture to support anything? You're not going to biopsy again.
No, exactly.
So
And
how do you decide? Like it's a random thing you pick 4 weeks, 6 weeks, and then is that enough really? Or not? Or are we overdoing it? Who knows?
I have this, people say do sequential cholecystocentesis, but that, the cytology is quite unrewarding of bile, and the culture was unrewarding. So what are we looking for in the bacteria in the background again? And there is a degree of normal enterohepatic circulation of bacteria. So a couple of bacteria, maybe that's normal. So yeah, I don't know how you monitor really.
There's a paper, because I looked at it, looking into if there's what is the normal flora of gallbladder, and they couldn't establish anything.
They couldn't establish the presence of bacteria normally.
Yeah, like they were trying to look at what is the normal flora, how do we know, and they couldn't establish. I'll have the paper somewhere, but yeah, it was very interesting because I was looking at it because we had a case and I was trying to figure out how do we this thing, but that specific paper didn't mention anything, and there's not too many papers on it.
So I'm interested in the techniques that they use to determine that, like if it was culture.
Culture and PCR.
And
I think
PCR was
both
okay.
from memory. I may be wrong. I will relook and I'll send you that paper.
Yeah, that'd be cool. There was a paper that looked at that enterohepatic recirculation of bacteria, portal, sort of goes portal, hepatocyte, and then into the bile kind of thing. And they found in cats that they could, on histo samples, detect bacterial DNA adjacent to the biliary structures. So whether that's ascending the biliary structures or come through the portal system, and I think they'd speculated that it came through the portal system. And the other reason that we know that portal circulation happens is because dogs with shunts get infections because the bacteria goes into systemic circulation and then seeds into disc spaces, heart valves, kidneys, stuff like that. Okay, next case that I'm currently working on. It's another cholangitis case, but so we had this cat who's 5 years old, previously well, presented acutely pyrexic and off food, and on bloods had an ALP of 200, an ALT of 200 as well. GGT was normal, and had a like borderline neutrophilia and a PCV of 28. The bilirubin was 32, so mildly elevated. So on ultrasound, the gallbladder had a bright mineralized wall and a fair bit of sludge in the gallbladder, which is you should never see sludge in cat gallbladders. There's something going on in the gallbladder if you're seeing sludge. How would you manage this case initially? What would your leading differential be?
Neutrophilic cholangitis or even lymphoplasmacytic. But lymphoplasmacytic, like with the textbook, it says it's actually a progression of neutrophilic,
yeah. And that's where what's the etiopathogenesis of neutrophilic cholangitis?
It's an ascending infection.
Yeah. It's most of the time infectious, bacterial infection. So this patient presents like an acute bacterial infection. It makes sense that it's a gram-negative organism because we get really profound pyrexia as an illness, more so with gram-negative infections than we do, or E. coli infections, than we do with gram-positive infections. They tend to be a bit more subtle. So this sort of makes sense clinically. How do you interpret the anemia? It's pretty borderline, 28 it was.
We just call it anemia of chronic, but it's not really chronic.
No, the cat, when they get inflamed, cats just like burst their blood cells. Like I wasn't excited about anemia. Yeah. The astute vet who saw this case got the cat back the following day to recheck the PCV, which was then 15.
Okay.
So this cat has IMHA.
Yeah, I was going to say.
Yeah. And I suspect the hyperbilirubinemia was actually IMHA all along. Because it went up quite a lot with the big drop in PCV. But this cat has, like, I can't make the IMHA cause the infection, presumed infection in the gallbladder. I can say that potentially the infection has triggered an immune response, which has maybe exacerbated or triggered the IMHA. So I think we've got two conditions going on here. So I've got to manage a presumed gallbladder infection with really quite aggressive IMHA. And this cat ended up getting a dog blood transfusion. And then PCV went up to 35 with the dog blood. And then all the dog blood died 5 days after, and it went back down to 13. And in the process of this, it was taken off the marbafloxacin that we were using to treat the gallbladder and put on doxycycline. We gave it a cat blood transfusion when it dropped back down. The cat's now on doxycycline, prednisolone. And the cat blood transfusion stabilized the PCV at 20, but it just didn't go up from there. The liver enzymes went like this. despite being on completely appropriate doses of prednisolone. So we switched this cat now back to marvofloxacin, hopefully to manage that infection, presumed infection in the gallbladder, which was probably rumbling along and not as acute and inflammatory as we thought, because the IMHA was probably causing the pyrexia. And the infection had to have been there at least 5 days before to have triggered that autoimmunity. You know what I mean?
Mm.
Following? Yeah. So we're sort of treating this cat for two conditions essentially, but really trying to balance it. We've suppressed the immune response with the prednisolone, so the inflammation in the gallbladder isn't as high, but the ALP is really climbing. So we've just started back on marvofloxacin.
Why didn't you use both together, like Marbo and Doxy, along with?
They've got quite similar spectrums actually. So doxycycline is cytostatic, bacteriostatic, and marvofloxacin is bactericidal. So theoretically, marvofloxacin works for Mycoplasma haemophilus, just in case as well, which is where I'd usually use doxy for that if we weren't treating the gallbladder infection. But spectrum-wise, marvofloxacin was probably a better choice for gallbladder and the Mycoplasma. Maybe. I mean, that was another medicine specialist to switch to doxy, so that you're going to get different opinions for sure.
Yeah. Would it be wrong to initially use it, then send the blood for PCR for Mycoplasma, and if it came back negative, then just continue Marbo? Like, would that be a wrong thing to do?
You're covering the Mycoplasma with Marbo.
Yeah, okay.
Marbo, the Mycoplasma is sensitive to Marbo, so you've not got a hole in your coverage because you're not using doxy with the two organisms we're suspecting, and Enterobacteriaceae and Mycoplasma, and Marbo will cover both of them.
What PRED dose did you use in this cat?
What? Sorry.
What PRED dose did you use?
We ended up using like 2.5 milligrams per kilo per day total, but divided.
Okay.
Slightly high on the higher end. Cats, I do feel like still need that sort of 2 to 4 kind of range. I'm always a little bit more aggressive in my pred dosing in cats than I am in dogs. And I don't think they suffer side effects. If they don't get diabetes, they're pretty good with it. So I'm a little bit more aggressive in cats. Having said that, again, like this sort of kind of going between specialists, one of the specialists dropped the dose of pred, and then the anemia didn't get better, so we put it back up again. But we'll see what happens. All right. I want to just cover one last.
Anna, one more question, sorry.
Yeah, sure.
So in this specific case, because we're saying it's the infection that's triggered the IMHA, would you treat for as long as you would treat a primary IMHA? Because like if you clear the infection, then the IMHA is not a problem. So would you then treat as long as the primary IMHA one would, or would you just do it for the initial period to stabilize and then just stop? Right?
So I just
not stop but taper.
Yeah, follow the consensus statement guidelines. This cat's PCV just hasn't bounced back nicely. So we're now a month into treatment and we're still below 30, like 29 now, but I still don't have that PCV in normal range to follow consensus guidelines to start weaning the prednisolone. So often you clear the infection, like if it's a UTI that triggers IMT, for example, in dogs, I think that's a relationship that's quite well established. If I clear the UTI, you see the platelet count bounce really fast, and then I wean quite fast. And I'll do that over 6 weeks. Whereas this cat, and clearing a gallbladder infection, I've heard it described as pulling butter out of a crumpet. So it just gets, because the gallbladder is not the only thing infected, it's this huge tree that penetrates like really small areas and has really poor blood supply. So delivery of antibiotics to the biliary system is pretty poor. So yeah, a few more considerations than like a UTI or something. But okay, we've got 2 more minutes. Last case. You've got a dog that's on prednisolone for its chronic skin disease. It's on 1 mg per kg per day. We'd never use prednisolone.
Yeah, like that's a high.
This is the last time I was a GP. We didn't have oclocidinib. So is that what it's called?
Yeah, oclocidinib.
Yeah. So yeah, now there's newer things, but so I've been on prednisolone 1 mg per kg for something, and for some reason you check the urine and you discover a non-clinical UTI, do you treat it?
I agonize over this so much.
I know, it's not straightforward, is it?
Is it wrong to wait for the dog to become clinical and then treat it?
I don't think there's wrong or right. And Edinger, that was the reference that I looked at yesterday, said you've got to treat with bactericidal antibiotics for 7 to 10 days. But I'm pretty sure the consensus statement says not to.
Yeah, the Edinger is not following antimicrobial.
Yeah, exactly. So we're interested to see next time we hit this chapter in Edinger, I'll be interested to see if it's different. Yeah. So that's the only things I wanted to particularly cover. Have you guys got any cases or anything you want to do? No? Good. We've finished Edinger. Woohoo. So
The brain though.
Sorry?
Nothing much is retained though.
No, I know. And this is, I read all these papers and I'm like, I can see that I've highlighted this before, but I have no recollection of ever having read it before. Yeah, so this is just going to be the rest of my life cycle, I think, is just reading it and just front to back over and over and over again. Keep up to date. I can't remember what it is in a fortnight, but we'll see you then.
Yep. Thank you, Anna.
Pleasure. See you guys. Bye.